behaviors. And you'll be interested if you are interested in electronic monitoring hand hygiene. It turns out that's really about healthcare provider behavior, which is what I've studied my whole life. And so this is a lot about our habitual behaviors. And that's what we're seeing right now, is that those mitigations changed some of our behaviors and allowed us to get make some ground up. The rest of the country is coming down too, and that's expected after a big surge like that. These things tend to burn out. People start to get to know other people that have COVID, and they get worried about it, and then they curb their activities, and then they stay home for a little while, and then when the numbers are coming down and they're feeling good, then they start to go out again and do more stuff again, and they start to think that things start to reopen, and that's where we run into trouble. We don't really have, because of the sort of the lack of economic support for businesses that have needed to stay closed for extended periods of time, like restaurants and bars, there's been always a constant push to get them back to open again in order to allow the people that work there and the people that own them to be able to resume their livelihood. And we want that for them, but we also don't want COVID to resurge in these areas. So the big questions right now are a lot about schools and getting schools back in person. Schools should be safe in person as long as you follow the mitigations that are there. And if a school isn't doing a great job with mitigations, it's important to bring that up to the school board or to the appropriate individuals and look at that carefully. But most schools have what they need now. Larger school systems like the Chicago Public Schools may have some spots where things really aren't being implemented as well, but their overall plan is really actually very good. We can, of course, answer questions about that if you'd like. The situation in Chicago is not expected to stay this way. I would categorize the current situation that we're in as a race between the vaccines and these new variants. So let's talk for a minute about the new variants and what kind of risk they pose, because I think that's kind of important here. And then we'll talk a bit about the vaccines. So the new variants are, just so that you understand, when we replicate our DNA in our cells, we have all these sort of like checking mechanisms and proofreading that make sure that things get done properly. And when they don't get done properly, we end up with abnormal cells that you've heard of, that can sometimes become cancer. Usually they just die, to be honest with you. But we have lots of proofreading mechanisms in our cells. Viruses don't have that. They are the minimalists. They are the light packers of the world. They are the people that go for a month on just a backpack. They don't bring anything with them. And so they don't really have any of these mechanisms. So when they insert themselves into our cells and use our own cell machinery to make their new copies of virus, they make tons of mistakes. And those mistakes usually end up in viruses that just aren't viable and can't get into another cell. But sometimes those mistakes are advantageous. Imagine a chain of, a lot of times kids will make those paper chains before Christmas, and they'll tear off one day. I remember doing this all the time. We'd make them in Sunday school, and then I would tear off one every day to get to Christmas. Well, imagine that those chains are actually what proteins are made of. And if you were to change, and they have a specific order of the colors that really matter in terms of how our antibodies can identify those proteins. And if you change out a yellow for a blue, that can make it hard. It might make it so that the virus can't do anything anymore, but it might make it so the virus can get into our cells faster. It might make it that it can turn itself over more quickly. It might make it so that you can get infected with it's easier for them to cause an infection with a lower dose of the virus than usually needed. It might mean that the person that has this infection with this, now that you have yellow instead of blue, can make a lot more virus, and so they can spread more virus. And what we have in these, in the viruses that came out in the United Kingdom, we'll talk about that variant B117, there's about 6 mutations in there that were known previously. So that's like a change out of those colors in the chain that were known previously to result in more rapid transmission of disease or to be associated with these super spreader events and things like that. What that ends up meaning, in short, is that there's good evidence, both in people and in test tubes, that this virus both makes people have more virus for every day that they're sick. So you have more virus, you're making more virus. So every time you breathe out, you have more virus in that breathing if you've got B117 than if you've got wild type COVID. And so that's a problem because that puts more virus out there. But there's a second issue. It also makes it so that they stick to our cells better, which means that it takes less virus for you to get sick. 1 or 2 little COVID viruses get in you, your immune system, your innate immune system is going to take care of that. But you get like maybe 1 million, then you're going to have a real problem. But this one, maybe it only takes 500,000. So we don't know the exact numbers of doses for this virus yet, but the point is that it takes a lot less. So people are putting out more and it takes less to make people sick, which means that all of the things that we usually do, washing our hands, wearing our masks, keeping our distance, using good ventilation, those all matter. They make a huge difference, but we have to do them better. So any place where you might have cut a corner, where you might have noticed that your friend's mask was under their nose, but you didn't say anything because you didn't want to be rude about it, that sort of thing could result in infection now, when it probably was pretty forgiving as long as you had a mask on before or there was enough distance. So these are the sorts of things that we need to be attuned to. You'll hear people talk about wearing your masks properly. The thing I think is most important is focusing on the fit of your mask. It needs to be snug and tight. You don't need 2 masks. You don't need to wear an N95 in most situations. There may be some where that's necessary, but it's actually not as much as you might think. You really don't need to have fancy masks that are hospital grade masks. A good quality 3-layer or even a 2-layer, as long as it's really high thread count cotton mask, is good as long as it's snug and tight, no gaping, snug over your nose. None of these things that are just sort of like loose, stretchy face covers and like gaiters and bandanas and scarves, those are not going to work. So you need to have just a good quality face covering that doesn't gape. And you can see that in the recommendations that CDC's made about wearing face protection in public transportation now. So that is one of the variants. There's the variant from South Africa, which is B1351, is very similar to the one in UK, except it appears as though the vaccines don't work quite as well for it. And we're going to talk about that more when we talk about the vaccine. So set that aside for a second. But for now, just note that it's otherwise very contagious. Both of them might make people sicker. We don't know yet. They might be more likely to cause death. I have to tell you, I think it's pretty reasonable to expect that they will. I think it's overly optimistic to say that they don't, because first of all, they're going to make more people sick than the other virus, and that's going to make more people die. Secondly, if you make more virus and you have higher viral loads, that's usually associated with a worse outcome. For some individuals, it's not going to make a difference. Maybe it won't make a huge difference on a population level, but you don't want this virus, period. Then there's the virus that's coming from Brazil, the P1 variant. That one we know very little about. It's more contagious. It appears to take advantage of individuals or be able to cause recurrent disease in people who've had COVID before, which is really concerning. But we don't know very much about the vaccine or about any of those aspects of it. But again, masks, distance, ventilation, hand washing, those sorts of things are really important. Vaccines. Oh, in short, these new variants are concerning. They are not something that should make you feel like you're in dire trouble. They should make you feel like it's time to take stock of what you're doing and make absolutely certain that you're doing everything that you can when you do go out. You don't want to be cutting a corner somewhere that you never meant to cut and that isn't all that big of a deal to not cut. Like, wear the better mask, not the junky mask that is great for running outside in the summer, but isn't so good for when there's new variants coming around in the winter, right? So just think it through and don't just grab anything, but make sure you're making good choices. Now, vaccines, these are great. So the vaccines are so good. And it is literally a race to see that we can get enough people vaccinated to stop these other variants from getting a hold in the United States. And a lot of that is not on individuals. As you know, it's really hard to get vaccinated unless you're a healthcare worker right now. So just stick with me and I'm going to go through everything. So the messenger RNA vaccines, those are the first 2 that were approved. Those are words that you may not know, or they might remind you of your high school biology class, and then you get like sweats and shakes. But I promise you, it's not that bad. So these messenger RNA vaccines, the Moderna and the Pfizer, they're 2-dose vaccines. They're very, very good if you get both doses. We don't know very much about how good they are after 1 dose. They're probably about 50% effective, but we don't know how long that lasts because no one did a trial of just 1 dose to wait and see. So it's best with those to get both doses whenever you can. They tend to make people feel a little bit sick, especially after the second dose, but this has nothing to do with the vaccine makeup. There's nothing bad in the vaccine or toxic in the vaccine. There's no preservatives in the vaccine. You can't get COVID from the vaccine. It's because these vaccines have your cells literally make that spike protein that is sort of like this, the most important piece of the outside of the coronavirus. That spike protein, it tells your body, gives your body the recipe to make spike proteins and put them out there. And then your immune system gets to take a stab at them. They look at them and go, I need to get rid of those. And they make up all the cells that they need after the first dose. But the second dose is when you really get that trial run. It's like, after you go to a software, you learn how to use a new software and you're like, oh, whatever, I got it the whole time you're in the class. And then when you go to actually do it yourself and use it, the first day you really use it, you're like, whoa, okay. And then you have to like figure it out. But by the end of that day, you're good to go. That's what the second dose does. So you really want that. But the feelings that you have are not some sort of infection. They're your immune system practicing. And that's really important. So it's good. Now you'll be immune even if you're lucky and you don't get those symptoms. But some of us, myself included, were not so lucky. I was kind of ill after my second dose. I got both doses. I got Pfizer because that's what we have at University of Chicago. First dose just made my arm sore. No big deal. Second dose, it was great for 12 hours. Then I got a fever. And I had a fever for about 3 or 4 hours. I was really achy, like the same old thing that I had the last time I had influenza, which was many years ago. And my back was hurting and I was sore and I had a fever and I felt miserable and I took some ibuprofen and then I felt better and I went to sleep. And it started at about 9 o'clock at night and I went to sleep and I just was real tired. I think I got out of bed at noon the next day. And the worst thing was the house looked like I had left a 12-year-old in charge of my house for a bunch of hours. And that's exactly what happened. It was like, what happened here? But by the evening, I felt good enough to clean it all up. So it was good. It was fine. It was not that bad. It was worth it. I definitely think it was worth it. So the story with the vaccines is that they work really, really well. They're 95% effective after that second dose at preventing COVID, not just preventing you from ending up in the hospital. And that's really important. Now, could some people get asymptomatic COVID and just fly under the radar and not realize it and maybe even give it to other people? Yes, that is possible. And we don't know how often that happens. I don't think it happens very often, but until we know for sure, you really need to keep your masks on when you're around other people after you've had both your COVID shots. The newest vaccines just had news out last week. This is the Novavax vaccine and the Janssen, which is an arm of, or Janssen, which is an arm of Johnson & Johnson. They're both DNA vaccines, so very similar. They don't use your genetic material. They use the machinery of your cell to translate this genetic material into the proteins that you need in order to warn your immune system about what's coming. And it doesn't change, none of them change your own DNA. They don't get into your cells and change that stuff. In fact, the messenger RNAs, vaccines degrade within an hour of them being given to you. So they're gone. They don't even travel past your arm. That's it. These adenovirus vector vaccines that have the DNA, they have to put it in another virus in order to sneak it into your cells. The messenger RNA is a little easier. Well, they did a lot of work and it was actually pretty hard, but it is now a little easier. But the adenovirus vector vaccines, they use that virus, but that virus can't replicate. It doesn't do anything. It's just a way of getting that stuff into the cells so they can make the spike protein again. Same thing. The Johnson & Johnson, it's a little, you hear the news and they say that it's only 65% effective and you're like, oh my God, I don't want that one. But stop for a second because that's with one dose. The 2-dose results for Johnson & Johnson, we don't even have yet. And so the 1-dose results for Johnson & Johnson are stronger than what the 1-dose results probably would have been for Moderna or for Pfizer. So if we're in a situation where we're not able to get people second doses right away, then that Johnson & Johnson vaccine is a really good option. None of these vaccines are great against the South African strain, but we don't need to worry too much about that because they did prevent people from getting into the hospital or getting or dying of COVID. They just didn't keep people from getting COVID. And I think we got a little spoiled with the news from the Moderna and the Pfizer vaccine, because before those came out, I would have been thrilled with a vaccine that turned COVID into a cold. And so I think before we throw these out, we should really consider if you can get a dose of one of those. Neither has been approved, and I would say this: I haven't seen the actual data. We've only seen the sort of press release data, but some of my colleagues are involved in the trials and have been really favorable about them. But I think assuming that what we see when the actual EUA data is released or emergency use authorization data is released is what they say it's going to be. Then I would not hesitate to get one of those if you were able to get one. I think that they'd be good, especially the Johnson & Johnson seems to be next. I don't think Novavax is on the radar I think they're waiting to get their EUA. I think they have a little bit more work to do. Okay. How much time did I spend? That's like 20 minutes of me just babbling about COVID. I could do this for hours. But I think it's time to get to some questions. Paul, do you have, Pastor Paul, do you have some questions for me?
I've got some questions for you. That was great. That was awesome. So thank you for that. That was really good. Yeah, so we've got a bunch of questions. More are coming in. So just a quick reminder, if you have a question, you can put it either, if you're with us on Zoom, put it in chat or in the question and answer. If you're with us on Facebook, write it within the Facebook comments, and I'm monitoring that, and I'll throw that in as well. If you're not on either and are watching this somehow, maybe you're watching it on our website or something, and you want to get in touch, you can text me 309-716-8456.
I can't believe you're putting your phone number on YouTube.
Oh, it's okay. It's on there every Sunday. So I'm just, it's out there. It's out there. It is what it is. My good old doggy number, good old 309 area code. Okay. So let's jump. Let's see, Ken. And by the way, just apologies if I say someone's last name terribly wrong. And most of them, I'm not going to say the last name. This one I think is important. I think it's Ken Graff or Grafe, who said, how important is the 90-day wait period between contracting and vaccinating, and why? And then he says, P.S. Conrad from Bethany says hi. So,
hey there. I just wanted, so the 90-day thing goes like this. If you've had COVID, there's really great evidence that you are immune for 90 days. There's actually growing evidence in the last few weeks that it's more like it's at least 180 days. And that's based on these large scale trials of people that have been getting COVID since the spring. So the reason to wait 90 days is not because anything bad's going to happen to you if you get the vaccine. It's because we don't have a lot of vaccine and you're good to go for 90 days. So just wait your turn and leave that dose for someone else until those 90 days have passed. You could probably even push it a little longer, but depending on, how mild your COVID was, you might not want to. 90 days is the number we're using now. Just stick with 90 days. You might have a more significant side effect to the vaccine. So your immune system is going to be all revved up and ready to go. So it's going to be on the ball when you get that vaccine. It may need that in order to have good long-term results, but you might have a little bit more significant side effects if you got the vaccine earlier, but that's nobody who's been in that situation, and lots of people were, has had anything bad happen. The real issue is just that we'd like you to wait your turn so that someone else can get immunity since they haven't had it yet.
Great, thanks. The next one is one that you
just while we're talking about people who had COVID previously but have been more than 90 days are more likely to have that febrile reaction, the one that I had to the second dose, are more likely to have that after the first dose. Don't let that deter you. The second dose usually goes just fine.
Great, thank you. Thanks for that. This one you answered a little bit ago, but just to kind of wrap it up into a short answer, Mary asks, when might we expect the approval and availability of the one-dose vaccine? By the way, as the spouse of a Swede, I appreciated the Janssen in there. So you're talking about the Janssen & Janssen.
I think they're actually from the Netherlands.
Yeah, it's it's somewhere over there. Yeah. Anyway, so the approval and availability, when will those be available?
Yeah, so the Johnson & Johnson vaccine is expected to go up for EUA as a one dose soon. It'll have to redo the EUA as a 2-dose, but then remember, if you've gotten your 1 dose, that's going to be a more extended dose 2-dose. So it's not going to be like 3 weeks later you need a second dose. It's going to be like a few months later you need a second dose. That's how they designed their trial, and so that's what we'll be looking for. If those 2 doses turn out to be much better and there is a plethora of vaccine, you can always get your second dose after the second dose trial gets its EUA. So I think it's a good choice, even though it may seem on the surface like it's not as good. I think you're good. Just don't throw away your masks. Like, I think we all need to get, I understand that there are things that we want to do that don't have masks on, and we don't love wearing masks, but you need to love your mask a little bit. That's it. I have nothing better to say about that.
No, that's the quote people take for the night. Love your mask. That's it. Tom Voss actually stole my question, which I appreciate. Yeah. So, and I know you knew his mom and things like that. He has the same question I had too, which was, what is long COVID and what are the symptoms of long COVID?
So long COVID is when someone has COVID and they just don't get better. So they stop making virus and they stop spewing virus out. They're not really contagious anymore, but they seem to still have a lot of symptoms. And those symptoms are different than the beginning of COVID. So most people with COVID have cough and fever and chills, and it's a lot like influenza. Some people have more GI symptoms like diarrhea or nausea and vomiting. And some people just feel really, really tired with myalgia. There's kind of 3 kinds of COVID. It's not 3 different viruses. It's just the way we respond to them. But people who have long COVID have a tendency to keep the fatigue. They may or may not keep the fever. Most people lose the fever after a short period of time, but they feel very tired. And then they have these random other symptoms. Sometimes their taste and smell doesn't come back. Actually, for most people who lose their taste and smell, it takes 6 weeks or more for that to come back. But some people can have it gone for even longer. Some people just have a lot of issues with other neurologic things where they're having cognitive problems, where they're feeling very slow and just not able to attend to things the way that they used to. There's some growing data that there's actually difference in neurocognitive testing in those individuals. And then others have ongoing cough, but that's actually not the most common thing. And that's probably the easier part of long COVID to treat because we can use inhalers and things that we often use for post-viral coughing, which happens a lot. But it's the ongoing neurologic issues and the sort of, some people have joint swelling, and it looks like it's going to be something autoimmune, but it may be a plethora of a lot of different diseases. We don't know very much about it yet because not that many people get it. But if you do, there's not a lot of answers. There are, however, a number of long COVID clinics out there. And those long COVID clinics are meant for people who are having ongoing symptoms like fatigue and cloudiness and joint pains and things like that, going on and on for long periods of time. And they're studying it, and they're usually multidisciplinary. Now, that is distinct from and different from organ damage that happens during COVID. So if you have COVID and it's bad and you end up with damaged lungs, then you can have organ damage, and that has to be taken care of by a pulmonary specialist. That's usually just, you now have scarring in your lungs, and that can take a while to get over and might cause some problems down the road. Also seeing that in hearts. When people have inflammation of the heart from their COVID, they can have scarring in the heart and some inflammation in the heart that outlasts it. That's called cardiomyopathy or, myocarditis in this case. And so you can sort of need to be followed. We're often recommending that athletes get special checks before they go back to playing sports if they've had COVID, to make sure that their hearts are in okay shape. And then some people have kidney damage from if they were critically ill. And that's another one that you just follow with a nephrologist for. Those are different than long COVID because they're really just about organ damage that happened as a result of the illness. And then you just have to deal with the organ damage. Long COVID's another thing entirely. It's an ongoing problem that we don't understand very well.
Great, thanks. Sherry asks, once one is vaccinated, does one still catch COVID if exposed and consequently able then to spread that disease to others? Is that the same as being asymptomatic with the same likelihood to pass that on to others?
We don't know the answer to most of those questions. They're great questions, but I can give you some guidelines or some bumpers that will help you to understand what is biologically plausible. So about 40% of people with COVID don't really have any symptoms at all. So for every person that gets diagnosed with COVID, there's someone else wandering around with COVID that we don't know about, which is part of the reason why we have to wear masks and distance all the time, even with people that say they're fine and everything seems fine. It's not because we don't like people and think that they all have COVID. It's because they really could have COVID. So then there's the vaccinated people. So about 5% of people that get Pfizer or Moderna vaccines will have COVID. That's usually much milder than it would have been. So we assume that there's probably another 5% or so, maybe, that are able to get asymptomatic COVID. So the trials just didn't look at whether or not people were carrying around the virus COVID by swab. They weren't swabbing people's noses. In order to do so, they would have had to have people come back to the trial site like every single week to have their nose swabbed. And anybody who's had their nose swabbed knows that that's kind of a deterrent. And they wanted to get as many people in as quickly as they could. And 60,000 people is a lot of people for a vaccine trial. So you can see why that's a corner that got cut. However, because so many healthcare workers are getting vaccinated and places like my hospital, we test people every time they have an exposure. We're going to get a lot better data in the next few months about what the chances are that people are really going to be able to carry COVID asymptomatically. I think it's going to be pretty low, but I could be wrong. And so for now, you just need to keep that mask on and be careful. If both people are vaccinated though, and you carry COVID from yourself to the other vaccinated person, it's going to be more like a cold for them. So that's less of an issue, but you can't always know how well someone's immune system has done. So if someone's very old or has an underlying immune condition, then you might want to be extra careful. They may not have gotten as much benefit from the shot as you did, but I think that once you have two people who are vaccinated, it's pretty safe if they're still taking all the other precautions, if they're not throwing caution to the wind and doing whatever they want. You know, if they're still wearing masks and being careful and avoiding eating in restaurants and that sort of thing, it's probably okay for them to spend time together unmasked. But be careful, because some people don't want to say that they're not vaccinated. And so you really don't want to say, let's have book club in person, but only come if you've gotten both vaccines, that sort of thing. We shouldn't do that. That sort of encourages people to cheat and lie, and then that puts them at higher risk. And it also puts people in a difficult situation, and you've sort of taken away, you don't want to exclude people just because they couldn't get the vaccine or whatever. So there's a lot of I wouldn't do that.
Okay. And just a quick clarifying question just on that. Somebody thought that they heard you say that 40% of people carry COVID asymptomatically.
Well, 40% of people with COVID don't have any symptoms. It is not that 40% of humans have COVID. No, actually, it's much lower. So we know that what we see in terms of symptomatic positives on tests, it's like an iceberg. That's only half of the iceberg. There's a bunch of other people out there that are carrying COVID around. Now, of course, a lot of people get asymptomatic tests after they've had an exposure, or if they live in a congregate setting, or if they're, if you're going to have a procedure done. And sometimes you show up positive and you had no idea you had COVID. And that's what we're talking about. So that certainly happens. And you can still get some long COVID symptoms if that happens. And there's some things that can happen later on that can happen. So that doesn't save you from the other stuff. Better get vaccinated.
Great. Thanks. And love your mask, I heard too. So
yeah.
Dawn asks, how safe are teachers going back to in-person learning when they haven't been vaccinated yet? And especially with the new strains that are showing up across the country.
So teachers going back to classrooms are probably safer than people working in grocery stores and public transportation, people driving Ubers, people who've been working this entire pandemic, even without their vaccine. Schools are doing the best job that they can to make sure that everybody's masked. Contrary to popular belief, kids are great at wearing their masks. They're much better than adults are, because think about all the other things we make children do. We just basically expect them to do everything we say all the time and to live their lives however we tell them to. And adults are not like that. Children are very good at that. So the reality is that kids are much less likely to get COVID and less likely to pass it on. There is not a lot of transmission between children and adults, except in the family setting where you've got a caretaker, which makes sense. And this isn't like regular old cold viruses. So I know that a lot of people think cold viruses spread like wildfire through schools. And so how could it possibly be safe? Well, I think all you have to do is go on the CDC's website and look at the flu view. This is so much more transmissible than those other diseases that we have eliminated those other diseases. There's no RSV. Our children's hospital is empty. There's nobody with it. We've had 3 influenzas so far this year. At this time of the year, we'd be getting 150 a week in an average year. And we've had 3 total the whole year. So, the reason that this is contagious amongst adults. It is very different. It doesn't have the same surface contamination problem that you see with flu and with RSV. All of that stuff we have taken care of. And I really think that teachers need to look in their hearts and understand that they can be in the classroom safely. They need to be really careful about things like carpooling to work and not wearing masks with your colleagues. That's where our nurses have gotten into trouble. Eating lunch in the break room and hanging out with friends because we're at school together all the time. And so we're basically like a family. Not the same. You have no idea what those people are doing in their free time and who they're spending time with and whether or not they're going out to eat or doing risky things. You don't know. And so you have to be really careful about keeping your distance when your mask is off. You want to make sure there's appropriate mitigations and backup in place so that if there is a case, kids can get tested and the other kids who are exposed can get tested. But I've been helping Lab School and Parker, and I've worked with a number of universities, including University of Chicago and Augustana. And the reality is that in classrooms, there's very little spread. We had 3 cases at lab and none of them had any spread to anyone. And we tested everyone and kept everyone home for 2 weeks because masks, distance, ventilation, that stuff really does work.
Great, thank you. You had mentioned something earlier about 2 masks, and just to be clear, Dawn and Jennifer asked, what are your thoughts? Do we need to double mask it? We know we need to love our mask. I just want to keep saying that.
So it depends on what you're using for your mask, really. So the real benefit of 2 masks is that it holds the first mask tighter onto your face. And so if you really get a mask that fits well and that has good filtering capacity, so that means nothing stretchy, because when you stretch things, you can see the holes in them more. And that's what COVID goes through. So nothing stretchy. If you have, I think that fabric masks are great. I suspect that we'll be going to fabric masks at some point in the future for all of our medical masks, because it turns out they're far more comfortable. And the data that we have from some scientists at Argonne are that we can make them way, way stronger and better than those N95s that are made out of plastic and paper and have to be discarded, can't be reused, and can't be recycled. They're terrible for the environment. And I don't think it's a good idea to ask people to go out and buy a bunch of disposable masks when they don't already are having a hard time with affording things. Disposable masks have to be replaced a lot, and they run the risk of people not replacing them when they need to be, which means that they're wearing out, they're not fitting as well, they may have gotten wet, then they don't work at all really afterwards. So fabric masks are more durable, but you need one that's 2 or 3 layers that fits snugly. You want it to have that nose bridgey thing that's like a wire in there, and you want it to have ear loops that fit really well. There are good, there's new data out from the JAMA Internal Medicine, a journal of the American Medical Association, that suggests that things like those clips that you can put in the back that hold the ear loops together in the back, or ties that tie the ear loops together in the back, or having masks that have ties actually can improve a poorly fitting fabric mask to be better than a surgical mask from the hospital. And that many surgical mask wearers in the hospital probably need those things too in order to get the real benefit from them. We've been using fabric masks a lot. We switched to medical masks when they can get contaminated in patient rooms, obviously, because we don't want people donning and doffing a lot of contaminated masks. But if you're around other people that are masked, then a good fabric mask that fits nice and snug, it should be tight, and you should feel it moving when you're breathing. It's okay if it fogs up your glasses a little. The air has to come out somewhere, and it is warmer, but not if it's just fogging up completely. Those masks that kind of sit over your nose and mouth but don't really snugly fit your face, you know what I'm talking about. They're like a flat piece of material, and they're like kind of stretchy ear loops. They're not good. Those are not great. You want a good fitting mask. You don't need to do 2. If you're really worried about it, you can do 2. You put your better filtering mask on the inside, and then you put your fabric mask on the outside, so you can hold the papery plasticky masks from the hospital, those ones on tighter because they don't fit people very well. And we really worry about just telling people to use those. Plus, some of them that you can find at the store aren't really medical grade. So you don't know what you're getting. I say buy a mask from somebody who can make it for you. Help somebody out.
Great, thank you. Karen asks, I have an allergy to penicillin and thimerosal, I'm hoping I pronounced that right. Is the vaccine safe for me?
Yeah, I'm allergic to penicillin too. Anaphylaxed before. In fact, I'm anaphylaxed to like 2 foods and penicillin, and I did great with my vaccine. The thimerosal is important though. A lot of people know thimerosal. It's a mercury-containing component that is sometimes used to preserve vaccines. It's not in this. It would kill the RNA. That's why we have to keep it in those -80 freezers, and why it's so difficult to manage, and why they're so tricky. I don't know about the Johnson & Johnson vaccine, but I can tell you you're good with the messenger RNA vaccines. There's no preservatives, no nothing. They are literally just messenger RNA wrapped in a little bit of lipid bilayer, and they degrade really quickly in your arm. And you're good to go. You'll have to wait 30 minutes after your shot instead of 15. That's what I had to do too, but I did great. In fact, the new data out about the anaphylaxis rates, for as much as these have been hyped in the news, the anaphylaxis rates for both the Pfizer and the Moderna vaccine are lower than almost any drug on the market. They're really, really low. In fact, if we gave everybody penicillin, we'd have a lot more problems, way more problems, millions of problems a day. So I think you should feel really confident and get your vaccine. And if some people do have bad reactions, they are unusual allergic reactions. They are very rare, like 5 in a million is what we're looking at. In that case, then every place has to have a rescue set up there, and someone who can do the rescue that you need, like with an EpiPen and some Benadryl, and get you to an emergency room. We had one at the University of Chicago so far. We've given 40,000 shots, I think, and we've had one. And that person was pretty sick. They had to be in the hospital overnight, but they're fine now. So as those of you who've had anaphylaxis know, it is not something you ever want to have again. And you look at anything that might cause it with a lot of trepidation, but this is not something that you need to worry about. The only medications that if you've had an allergy to would be a contraindication are polyethylene glycol, which is a really long word, but it's what's in Miralax. If you are allergic to Miralax or to the Go Lightly prep that you have to take before a colonoscopy, you shouldn't get these 2 vaccines. Wait for another one. You might be able to take the Johnson & Johnson. Or polysorbate. Polysorbate is not something that you think of very much. It's a binder that can be used to stabilize dyes in things. It's actually used a lot in bath products. So if you're worried about polysorbate, or if you're really sensitive to things, go read the labels on some of your stuff. And if there's any of the polysorbates, 20, 80, 40, whatever, and you're able to tolerate those products, you're good to go.
Excellent. Thank you. Christine asks, is it better to wait for a new vaccine, which may include protection against the new COVID variants?
No, don't wait. Just get vaccinated. So I think people fall into 3 categories here, right? You've got the enthusiastic early adopters. You've got the people who are a little bit hesitant, and that group's getting smaller every week because there's better and better data coming out. And then there's the people who just aren't going to get vaccinated. And there's very little that I can say for them. We're going to set them aside. I would love for them to be vaccinated. I would love to talk to you if you were in that category. But let's worry about these. We don't have enough vaccine for everybody anyway, so let's worry about these first 2 groups, right? If you're an enthusiastic early adopter, just get vaccinated. They will protect you to a large degree from bad outcomes with even those variants that we don't know about. They will provide you with far more immunity than you have right now. And you definitely want to have that. Plus, these messenger RNA vaccines are really easy to retool. It's kind of like cookbook. It's like, the reason these things came out so quickly is because in the past you had to grow the pathogen in culture, then you had to purify it, you had to then extract whatever you needed or inactivate it some way or modify it, and then you had to make sure that stuck and worked properly and that was pure, and then you could try giving it to people. And every one of these pathogens has different conditions under which it's easier to grow and harder to grow. And then how do you turn that into something that can be done millions of times over without ever making a mistake, right? That's like making macaroni and cheese, starting with a cow and a sheaf of wheat, okay? It is a long way to go. Using these messenger RNA tools is like making macaroni and cheese with a box. You've got everything all lined up and you know what to do, and you just have to plug in the sequence of the spike protein, because these drugs have already been developed. They've been used and we've tried them for multiple other viruses. They tried a dengue vaccine, they tried a Zika vaccine. They didn't work. They were great. I mean, people did fine with them, but they didn't work very well. probably because those are different types of viruses and they just didn't have the right kind of protein on the outside that was easy to pick the highest value target for the immune system. Coronavirus is just good for that. And I honestly didn't think they were going to work. I thought they were going to be just like the other ones, like a great idea that doesn't work. Turns out that great idea does have its time, and it's with coronavirus. So, and they had been in development of a SARS-1, like the original SARS vaccine, but there was no one to test it on because nobody had SARS. So it was just sitting around. Modifying that to a SARS-CoV-2 is pretty quick. And so modifying that to the new one is also pretty quick. And it remains to be seen what we're going to need in terms of sort of regulatory compliance, like getting them approved. Like we don't know how much effort that's going to take or what it's going to be. But once you know the carrier molecule is safe, it's probably not likely to cause any more problems.
Great. Susan asks, she says she's heard of many people having reactions to the Moderna vaccine. She's planning on getting the vaccine, but if she has a severe reaction and so then refuses the second dose, will she lose the immunity to the virus?
Okay, so the reason you're hearing about more reactions to Moderna is probably because more people around here are getting the Moderna vaccine. So Pfizer and Moderna have about the same rates of side effects. Now, Moderna does have this thing where you can get a big lumpy swelling in your arm a week after you get the first dose. It's called an Arthus reaction. It's no big deal. It'll go away. You can get the second dose in the other arm. Don't worry about it. The rates, the fact is though that only places that have large minus 80 freezer capacity, which in a research institution like University of Chicago, we have whole rooms called freezer farms where you can rent out minus 80 space for your research project. So we've got a lot of them. So we get only Pfizer. So Pfizer is being sent largely to research institutions and places like that. Like Argonne's going to get all Pfizer. But out in McHenry County, where there aren't a ton of research organizations, you're only going to meet people who've gotten Moderna probably. And that's fine. You can go talk to my mom. She got her first dose of Pfizer. But anyway, everybody else has Moderna. And it's not any worse. And if you need to talk to your doctor before you decide not to get the second dose. We're actually giving people who had hives and didn't have anaphylaxis, so everybody but one, to the first dose, we're giving them the second dose of Pfizer. Even though they had an allergic reaction, we're doing it in an allergy clinic with appropriate pre-medications. So it's rare to have an allergic reaction. Having a bad reaction, you have to put that into context. If that is an allergic reaction, you need appropriate care and monitoring in order to be able to get the second dose. If it is, I had some side effects after the first dose where I had a fever and I didn't feel good, then you probably are going to be fine after the second dose. That may be the only way you're going to find out that you might have had COVID and you didn't realize it in the past. So talk to your doctor before you decide not to go with the second dose because you really want that second dose. If you never get the second dose, we don't know what happens to your immunity for the mRNA vaccines. I would assume that would go away over some period of time, that you would have some level of protection. We don't know how long that would last, and we don't know how long it would take for it to go away. I suppose we'll get more data about that with time, but I strongly recommend that if you can get both doses, you should get both doses. If you can't get them right in the 3 or 4 week time frame, don't lose sleep over this. Just try and get it as soon as you can. 6 weeks, 7 weeks, 8 weeks probably is going to be just fine. You shouldn't have to restart the vaccine process.
I just want to go over what you just said because someone else had just said, what if they got the first vaccine, but they couldn't get the next within that 3 or 4 week? From what you just said, it sounded like you're fine.
Yeah, CDC is saying to try not to stretch it beyond 6 weeks. The United Kingdom is telling people to just sit tight and not even bother until 3 months. I think that's not the best plan, but I think there's legitimate debate. I'm not saying that I just disagree with it on the merits, but I would say I disagree with it 30%, not disagree with it 100%, right? So I think that I think you should just keep trying to get on the schedule and keep going back to the place that you got your first dose at. If there's any way for you to schedule your second dose when you get your first dose, do not leave without getting it scheduled if that's an option. I know that the way we do it is that those dates open up, the second dose dates open up for you as soon as you check in for your first dose. And so you can immediately go in and get a date at least, 17 days later, whatever the earliest is you can get for Pfizer. But that's the best way to do it. Don't be like, oh, I have to check my calendar, I'm not really sure. Just get something on the books, because moving it and switching with another person, like for all you know, someone called in that said that, oh, I can't do Thursday night and you really want Thursday night, and you guys, the schedulers can just swap you. So just get something on the books so you have a spot held if at all possible. And Illinois is doing their best to not have to cancel appointments, which I know we're hearing about a lot in other nearby states, and some, I don't know of any in Illinois right now, but I wouldn't be surprised if there were some. We have not had to do it yet. And we don't think we will, now that we're getting a much better idea about how much vaccine we're getting on a regular basis.
Great. Jean asks, is it possible that we'll have to be vaccinated every year rather than just the 2 doses suggested now?
Yeah, it is possible, especially with these new variants coming out, that we may need additional boosters. I would imagine this would be something that would be pushed to be given along with your flu shot. And, I'm hoping it's going to be every 2 or 3 years. Because once everybody gets vaccinated, or a lot of people get vaccinated, you kind of remove the oxygen, and then the virus can't spread very much. And the less it spreads, then the less it replicates, and the less likely you are to have a new variant. So these variants are out there because there wasn't a vaccine. Injecting a vaccine into the situation and getting people vaccinated as quickly as possible stops these from emerging. So don't think that it's going to be some sort of constant race of like, oh my God, every few months there's going to be a new variant. No, that should not be the case. That's the race between the vaccine and the variants.
Carolyn and Lori both asked, is it safe to get a vaccine if you have an autoimmune disease?
Yes, I have rheumatoid arthritis. And I got my vaccines, didn't hesitate at all. A lot of people are worried about this because they're concerned that they might end up with a flare. I didn't have a flare. I actually decided to hold some of my RA meds so that I would get a better immune response. Don't do that unless you talk to your doctor. I am a terrible patient. And that's just how it goes. So you should talk to your own doctor. But I think there were not immunocompromised individuals included in the trials. And that can make people really nervous. But the reason they weren't included is because people like us are not as likely to make as good of a response. And they wanted to get the data as quickly as possible. The more people you include who aren't likely to make as good of a response, the longer it's going to take. The more months you need, the more people you need. And so the best thing we can do is get vaccinated, because everybody with an autoimmune disease is on some sort of immunosuppressant. And so you've got to get vaccinated. That's going to provide you it's a much thicker layer than the other layers you're using right now to protect yourself. And there's no untoward side effects in people like us. We've vaccinated thousands of them now and haven't seen a single lupus flare or RA flare or anything.
That's great. Thank you. Jan asks, how much exercise is prudent when one has COVID?
Well, that's a good question. You need to be very careful because of the heart damage and the lung damage that are not insignificant in some people. It's important to be very judicious with your exercise. Now, it depends on how much exercise you were doing before. So you want to cut back some. And if you're not tolerating it well, then you definitely want to talk to your doctor. If you are an elite athlete, or if you're working in an athletic situation where you're trying to push yourself all the time and you're really pushing yourself because you're trying to meet some kind of goal or train for something, and you get COVID, you may want to speak with your doctor and at least get an EKG and maybe a cardiac MRI before you return to training. If you are just a regular exerciser that goes for walks or runs and you're just doing your regular exercise, you can return to that whenever you're feeling better and whenever you're tolerating it. Just be careful and go slow as you go. If you have known heart problems, then you definitely have to talk to your doctor.
All right. Paul asks, what does 95% effective mean? I think you addressed this at the beginning, but if you just retouch it, what does that mean? Does it mean that I only have a 5% chance of getting COVID?
Yes, that's what it is. It means that you have a 5% chance of getting symptomatic, moderate to severe disease of COVID. And there may be an additional risk of getting asymptomatic COVID, but we just don't know that yet. but it is about a 5% risk that you'll have clinically significant COVID, like significant enough that you didn't feel well and you talked to your doctor and you asked to be tested for it. So that's a big gamut, right? The reality is that in the trials, none of the vaccine recipients were hospitalized with COVID. And even in the South African variant, where there were so they did trials in South Africa and a number of people got COVID, and a lot more than got COVID if they didn't have the South African variant, but they didn't get so sick that they needed to be in the hospital. And that's really important. And I have a puppy here. I've been handed a puppy who's been...
It's always good to add puppies into the mix.
Yeah, my mom said that there were requests to see Stitch, the puppy, who's been in a lot of in those Tribune Facebook Lives. He's growing now. We got him around Thanksgiving. He's much bigger now. He's a very good dog. He says hello. Oh. He's not going to get COVID, though. All right. I think he'll sit in my lap for a minute and
love it.
Probably chew on my fingers because he's teething.
Emily asks, this is not necessarily a COVID specific, but related. For nursing mothers who are vaccinated, what's the likelihood that they would be able to pass antibodies onto their infant? What have we seen from other vaccines that might give us a clue about that?
So most of the antibodies that are passed to infants are passed through the placenta before delivery. And then there's some that are passed in the colostrum in the very beginning, the very first milk. But after that, there's not a ton of antibodies that will protect babies from COVID that are going to be able to get into them. That you can get some GI antibodies and some important things for GI illnesses and mucous membrane things, but not a ton for COVID, we don't think. And you can't pass this vaccine on to the baby. You should definitely get it if you're nursing. And the new data out about pregnant women suggests that they have a much higher risk of dying or having a bad outcome for them or their baby if they get COVID. And we are vaccinating pregnant people and strongly recommending that they get the vaccine. And I think you're starting to see that a lot of places. So obviously, if you are at very low risk for COVID and you're hesitant about this, you can talk to your obstetrician. But we've vaccinated hundreds of pregnant women without any issues so far.
I'm going to go because I know that was a concern was about pregnant women and the testing, and the other was about children. Someone asked, will they be vaccinating children at some point? Is there a timeline on that? So
remember, immunocompromised individuals, pregnant women, and children are never included in this first trials of anything, unless it's literally for them. Because they are special populations and they are considered to be, from an ethical standpoint, to be in a different position, and you shouldn't put them in a position to get a new drug as part of a phase 3 clinical trial unless you absolutely have to. So that's why they weren't included. It's not because anybody thinks that anything bad is going to happen. It's because ethically we just don't do that until we've given it to a bunch of healthy adults first. So children are probably going to be just fine with this messenger RNA vaccine. They were only excluded because they are children. And there's currently an ongoing trials for 12 to 16-year-olds, and then there'll be a 6 to 12-year-old trial after that. I am looking for the nearest 6 or 12 to 16-year-old trial to enroll my child. But we expect to have, if they get enough enrollment, we expect to be able to approve some of the mRNA vaccines for children 12 to 16, because Pfizer can be given from 16 up and Moderna is 18 and up. So their trial for children is 12 to 18, but the Pfizer is 12 to 16. And we're expecting to see results of those and get an EUA for children in the summer.
That's great. Two questions from folks who just got their vaccines. So the first one comes from Sherry, who had just received the vaccine one, felt, as you had mentioned, you might a little fatigued, worried about how the second vaccine is going to react. Do you have a best over-the-counter medication that somebody should take?
So there's a lot out there about not taking Tylenol or ibuprofen beforehand, because in one pediatric study, they found that children didn't have as good of an antibody response if you gave them Tylenol before their shot. And that turns out, I don't know if that's really true or not. Okay, but just your symptoms aren't going to start right after you get the shot, so you don't really need to take the Tylenol or the ibuprofen beforehand. I'm recommending that people start at about 6 hours after their second dose. And that's when I would start, and I would use either Tylenol or ibuprofen, whichever one is. It's my background.
I need a zip ties.
I think about 6 hours after is when I would start. The vast majority of people who have symptoms have it about 12 hours. They start about between 12 and 24 hours after the dose was given. Some people start as early as 6, but most people start between 12 and 24. A few are a little later than 24, but the vast majority are 12 to 24. And it's not predictable, right? More than half the people have no symptoms. A lot of people have very mild symptoms. I never get fevers. I was shocked I had a fever. I was so annoyed because I thought for sure I was going to be fine. I was not, but I got over it. It was not like being sick, because when you're sick, you get better slowly. You're feeling better, but you're still really out of it. And then, you're congested and you have all these lingering symptoms. It was nothing like that. It was like, it was a little bit, because it was like 3 hours, but very compressed, like 3 hours. It was kind of rough. And then it was like 12 hours of feeling really tired. And then I was basically back to normal. Like nothing had happened. Like it was not the way I usually feel when I'm sick. It was very clean.
Wonderful. Paul also talks about that they got the vaccine this morning. They're excited. They're looking for best advice now that they've had the vaccine into what they should do in terms of social distancing, masks, and for how long they should keep doing those things.
Don't change anything. Don't change anything until the community rates are low. When you see the community rates so low that things are going back into like really being wide open and no one talking about variants and like reporting no deaths on most days in Illinois, that's when you can start to cut back on those things. Stick with your mask, keep your distancing. You are not immune yet. Your vaccine, it takes at least a couple weeks for you to have any antibodies from that first dose. And then you have to wait and really until 2 weeks after your second dose. And then I would still I'm 2 weeks out for my second dose or longer. And I'm still wearing my good mask that fits snugly. I'm still watching my distance. I'm still avoiding places that have poor ventilation. I go to the grocery store, but I'm not going out and doing a lot of other things because there's still a lot of COVID out there. And every time we get COVID, even if it's asymptomatic, we're perpetuating and spreading and causing more variants and just putting other people in risk. I just couldn't stomach that. I can't imagine. I hate having to give someone else a disease. That's really hard for me. Maybe that's why I work in infection prevention. It's okay.
Stay the course. Stay the course. Love your mask. Hearing that, I'm just going to speculate. I think I know what your answer is going to be, but what are your guidelines for going into restaurants now that they have reopened, as well as who you go with?
Restaurants shouldn't be open. I've been about as honest about this. The only reason restaurants and bars are open is because we have failed as a nation to provide any backup for them. Nobody in public health thinks this is a good idea. The reality is that when someone with COVID comes into one of the, if you go in one night and no one with COVID comes in, then you're going to be fine. But if one person walks in with COVID, they're going to have their mask off for an hour. We have no idea what the ventilation is. American ventilation is meant to be efficient. It tries to keep everything in. We are not set up for filtering out COVID. And unless a lot of these places have put in really specialized ventilation systems, which I doubt they can because they haven't been open enough to have enough money to be we just haven't helped these businesses through this time. And so instead we keep opening them. And that is not a good plan for public health. It's a terrible idea. You should close bars and open schools. And I would need it a restaurant indoors and maybe outdoors, not in a big tent outdoors either, just like my own tent or, when the weather's better. But I would not. I don't think it's safe. And I don't think it's safe to have them open. And I'm on the record saying that I'll never get a reservation again in this town. Sorry.
So a couple of people have asked, how do you sign up for vaccinations in different places so that you can get it as soon as possible?
If you qualify because of your age or because of your medical status, the first place to look is your doctor. If they don't have a connection for how they're getting their patients vaccinated, then you should look at Walgreens and CVS. or you should look at your local public health department and their places. Get on all of the lists that you can possibly be on. If you can be on a list with the public health department, be on a list there. Also be on a list at your doctor's. And then Walgreens and CVS has been releasing new spots for vaccine every night at midnight, because that's when people 75 and older really need to be online. Just understand it. We release concert tickets like at 10 a.m. on a Tuesday, but we release vaccines at midnight every night. Yeah, you have to have somebody who's savvy go in and check every night at midnight in order to get yourself a vaccine spot at those places. If you have been to an academic medical center or a large hospital or a place that's been vaccinating their workers in the last 24 months, download or figure out how to get involved in their patient portal. Oftentimes, most hospitals are doing what we're doing, where they are sending invitations to people to get their vaccine based on their age or their comorbidities through this patient portal. We're also calling people, but we can't call people nearly as fast as you can get the invitation on your patient portal. So MyChart or whatever the patient portal is, and if you don't have it, call the hospital and ask them what you have to do to make sure you don't miss a vaccine, any hospital that you've been to. Even I'm sure that the Centegra centers have got some sort of a vaccine plan, so you got to talk to them. I'm sure they also have a patient portal, so definitely get on that. And I think, and I know Northwestern's doing that too, so I think that'll be the way that you'll hear about it, because I think they're owned by them now. So that's the best thing. Now, if you qualify through your job because you work in a place that is a 1B category, or if you're a healthcare worker, then like police, firemen, teachers, call your employer first. They may have already set up a plan. No, yeah, but he's biting my hands. It's fine. Call your employer first, because they have the information that they may have a setup for you already. If they do not have a setup for you, contact the local health department and get your name on a list with the local health department.
So in a related question, Wendy asks, for a healthy person in their 40s who's a non-essential worker, when can those of us anticipate being eligible for a vaccine?
So I think it's going to be sooner than everybody says, because I think vaccine production is going to pick up. I think that Johnson & Johnson will be approved, and I think that that'll really help the supply chain. And I think there's a lot of hesitant people out there. So I think we certainly got through our healthcare workers faster than we expected, largely because some of them didn't want vaccine. Now they want their vaccine. They're getting it now. But that is part of the reason that 1B came faster than anybody expected, because there were large swaths of even healthcare workers who were worried. And I just don't, that's unnecessary. So I think if you're an enthusiastic early adopter, I suspect that you'll be able to get vaccinated. That would put you in wave 2, not even 1C. So I think you're going to be looking at summer. But it could be sooner. So just keep your eye on the news. That prediction is like asking me to tell you who's going to, I suppose it would be easier to figure out who's going to win the Super Bowl. I mean, I just don't know. There's so many variables. And up until, January 20th, we got no information about anything. I don't think I can stress how real that is. Like, we literally would get a tracking number texted to us at our pharmacy director would get a tracking number texted to him that we were receiving a vaccine shipment in 2 days. And we wouldn't even really know, except based on the size of the shipment, how many boxes of vaccine or how much vaccine we were going to get. So you can't plan ahead or schedule appointments or do anything when you don't have that. It's fine when you're just vaccinating the people that are employed there and they're there all the time, but that's not really going to work for the general public. So this new system where they're really getting it sorted out is going to make a big difference, I think, in terms of the efficiency. And I know Illinois is working hard, but is a little bit behind the ball on this one so far. But I'm hoping that they get their act together, the county health departments. The hospitals have really done a lot of the work. And I know out by where you guys are, you don't have, Northwestern, Rush, and Loyola and University of Chicago vaccinating up all their patients and getting, doing thousands of shots a day. And it's hard to find enough people to do the vaccine clinics and the places. And it's actually really complicated to get through the process of getting the vaccine from the freezer into the arm. It's multiple.
He was gonna die.
Multiple steps.
No.
Real quick, Jean just wants everyone to know that she had her name on 7 lists, and then she finally got an appointment at Meijer. While she was waiting in line to get the vaccine at Meijer, she got a text about another possibility to get the vaccine. So be persistent. Yes, thanks, Jean, for sharing that.
Lots of lists. You should, who said that?
Jean said that. Jean Tolsman said that.
Jean, you should offer to do this for people as a service, getting them on the list.
So talk to Jean. How do you sign up for different lists? Talk to her. So a couple of people have asked, related to what you were just talking about availability of vaccines. And I don't know if you know the answer to this, but they're wondering why it seems McHenry County is the last to get vaccines when our case numbers are so high compared to some of those collar counties.
You're not the last. It's just that Cook County has a slightly better system. And I think that the health departments are slightly bigger in some of those other counties, whereas McHenry County's health department is pretty small and understaffed. And I suspect that so right now with all the large scale testing programs, so hiring enough nurses and medical assistants to run your testing program, sort of sucked up all of the supply of medical workers. So now you need to find people pharmacists who can dilute the medication and manage the refrigeration process. And then you need nurses who can check for symptoms. And then you need MAs or somebody qualified or pharmacists to give the vaccine. And this is you need a lot of people. And there just aren't people out there to do that. So a lot of places have positions open. And they the governor just authorized for people who have been in retirement, their licenses can be reactivated you don't need to do anything. It's just automatically extended if you're recently retired. So if you want to help out, contact the Henry County Department of Public Health and say, hey, I can help give vaccines. And I'm sure they would love to have you. It is not that complicated to give a shot. But you do have to have some qualifications to click the boxes saying that someone said they weren't allergic to polysorbate.
Great. And then could you speak to some of the conspiracy theories? One person had someone tell them that the vaccination causes sterilization. Yeah. And so what can you tell us so that we can help inform people intelligently?
Yeah. So I don't know where that stuff comes from. No idea. I don't think I operate in that part of the internet where those things happen. And I'm pretty sure Google knows that I'm not going to listen to that because none of that ever comes up for me. But I know people are saying it. Now, here's the thing. This vaccine does not cause any problems with fertility. I think the kernel of truth in that is the issue that they were recommending against pregnant women getting it in the United Kingdom. And that recommendation also said if you were planning to become pregnant in the next few months, because they didn't want you to not be able to get your shot and then get pregnant because they were very concerned about this. I have no idea why they were very concerned about it. We are not very concerned about it, probably because they started giving it before the DART trials those are the animal toxicity trials were out, which we now know that there's really nothing. It degrades so quickly. So I suspect the kernel of truth was those recommendations, and it led people to think that it might make you sterile. That's not the case. There's nothing to do with fertility. There is and all this stuff about it being similar in shape to the placenta, to a protein in the placenta, that's not true. The collection of amino acids is so small that is similar to a protein in the placenta that your immune system can't even recognize that. It's too small. So even the things that sound very sciencey, that's just not true. And there is no tracker in the vaccine. There's no microchip in the vaccine. Think about this logically. I think that comes from weird conspiracy theorists. But think about it logically. The vaccine dose comes in vials that have 5 to 6 doses in them. How could you separate out, make sure you're getting the right tracker into the right person at the right time? There'd be no way. And how would you keep track of which tracker? Because you can't see them. They'd be nano trackers, right? So it doesn't make any sense that you could put individual trackers into those vials. Plus, I have never seen it. I mean, my watch does a lot of things, but it's not that small. I mean, I don't know how small you think these things are, but there's just not, we don't have those kind of robots readily available enough to put, and you can see them still. So I don't think that's not there is no microchips in there. There's no sterility. And then what other one? That there's a separate vaccine for Black people. I've gotten that actually from a lot of people. It's such a pervasive idea that we've actually gone to in our vaccine center. There's multiple rooms, and you check in, and then somebody points and says, you go to room 1 because it's open. And, they just send you to the one. It's like, a lot. It's like when they do the lines at the grocery store that way. But instead of that, or like when you're going through customs, but in this case, we let people choose the room that they want to go to, because they said that would really make them feel like there wasn't a separate vaccine for people of different races. So and anything to help people understand, it's a real issue that we have there are a lot of individuals who are African American or Black who feel as though this vaccine is being pushed at them because we want them to test it now. And I think a lot of our work trying to engage that community in some ways has kind of backfired. So it's really important that we all have options and access to the vaccine, and that it's clear that it's just really important that we get it to individuals in these communities that have really high mortality rates.
Do you have to, I don't think this is the case, but do you have to live in the county where the vaccine is given?
No, you do not. There are some programs for which they want you to do that. The public health department programs, they are only authorized to give to people who live in that county or work in that county. If you qualify in that county, either because you live there or you work there. So say my sister who lives in McHenry County but works in Kane County and is a pediatric therapist, she can get vaccinated in Kane or in McHenry County from the public health departments because she qualifies in both counties. She actually got vaccinated, I think, in Kane, or will. I have no idea. Whatever. She got her first dose. She's getting her second dose soon. Same thing is true. If your doctor is in a different county, you can go to that county to get it from your doctor. But if you have no connection to a county, it's going to be hard to get on their list.
Great. Someone had asked how long, and I think you addressed this, but just do we know how long the Moderna and Pfizer vaccines last?
No, that is the biggest corner that was cut in order to get them out quickly. A lot of people are worried about the corners that were cut. That's the one we cut, because I don't know about you, but I didn't really want to sit around and wait and see if those 60,000 people who got vaccinated, if it lasted a year. I wanted to get it right away as soon as I knew it worked. So that's what they did. They followed the people long enough to know that it was safe, because about 95% of these long-term consequences that people talk about, they all start early. They may last a long time, but they start within the first 6 weeks. So that 8-week time frame after the second dose was plenty. And once we realized that people were doing fine, and they did great with the vaccine, so we wanted to get them out. So those people that were in the trials are a few months ahead of the rest of us who are getting vaccine, and they're still being followed. So we now know that at 4 or 5 months, those individuals are doing great, and they still have a ton of immunity, and they're not catching COVID. So far, so good. What we'll do is, if we start to see immunity waning or COVID rates increasing in that population as part of the study, then they'll recommend another booster for people who've gotten that vaccine. And that'll be a pain in the butt if it comes soon, and a real down, like it'll make me feel very sad, and it will be very hard to accomplish. But the immunity looks so good, and people did so well, that I think it's going to be a while.
Going back to just the virus itself, Margaret asks, if someone has a mild case of COVID or no symptoms at all, they're asymptomatic, does that mean that they will or could spread a mild case?
You can spread a mild case of COVID. I would think that a vaccinated case of COVID would be less likely to spread than a mild case of COVID, but we don't know that for sure yet. In the past with other diseases, that is how it works. You're less likely to spread when you have a breakthrough case after you've been vaccinated than if you just have a native case but aren't very symptomatic. But you definitely can spread COVID when you're asymptomatic, and you can spread COVID when you're pre-symptomatic. So in the couple of days before you develop symptoms, before you even get sick, you're spreading COVID. You are the most infectious 0.7 days before you develop symptoms.
And just to clarify too, with that, if regardless of before I'm vaccinated, like me, I haven't been vaccinated. Right. If I have COVID and I'm either asymptomatic or say I get a really mild case of it. By the way, I'm not. I just want to be clear. But I can give somebody a full case of it though. Like they're not. I'm not just giving other people mild cases. I can give them a bad case.
You can give them dead cases, yes.
Okay.
And we see that happen a lot. I didn't realize that it was that bad. My daughter wasn't that sick. How am I so sick that I'm in the hospital now? It is not, I have heard those words, and it's very sad.
We had a question about dentists. Are dentists being asked to administer the vaccine? What's your take on that? Seems like they'd be good at doing something like that.
Yeah, I think that'd be fine, but I don't think they are. I think that most dentist offices are just getting vaccinated by nearby healthcare centers. Like, so the hospitals that were giving their own people, like our hospital, we just sent messages out to all of the people that were listed as healthcare providers within a certain number of miles and said, if you need to be vaccinated, just fill out this form and we'll do it. And I sent my dentist to our hospital to get vaccinated, or my dentist's office, I should say. So I think most of them are going to other places, but I'm not sure. There's probably some sort of licensing issue about who can actually administer. They may not have the capacity to store the vaccine in their center. There's the storage and administration of this vaccine is super complicated, and even if you can like get past the -80 business, there's a lot of other stuff that goes with it. Like you have to have like 5 people lined up right away. You can't save that for more than like 30 to 45 minutes. So like you have to be like ready to do them all. And you have to have like an assembly line going in order to get everybody done in time before you time out on the doses. So it's a little tough for a dentist's office to do it, or a primary care office. You got to have like a vaccine clinic running.
So we have one final question. It's one that we touched on. I just want to touch on it because I've had 3 people ask me since, so I just want to be clear about that. Before we do though, Jean is amazing, and it put the link to Meyer where you can get vaccinated in the Zoom chat. Nice. Jean, you're awesome. So it's clinic.meyer. That's Meyer, MEIJER, like the grocery store.com. All right, last thing, a lot of folks are concerned because they had an anaphylactic reaction to a flu vaccine or a flu shot, and so we've had 3 more people that are just worried about, should they be concerned? What should they do?
Technically, if you had anaphylaxis to another vaccine, you should talk to your doctor or to an allergist before you decide to get vaccinated. But I don't. Our allergist is saying that she doesn't think that there's any reason to be concerned. These vaccines are so different than the other vaccines. They don't have the same components in them. The only thing that is a real contraindication to getting this vaccine is having an anaphylactic reaction to this vaccine, or its components. So having an anaphylactic reaction to a different vaccine is not a contraindication. If you're worried about yourself, talk to your allergist, talk to your primary care doctor before you go. I would not hesitate to get it.
Dr. Landon, thank you. I mean, I think I speak for everybody here. Thank you. Thanks everybody who submitted questions. This has been so amazing and so refreshing, I think, for all of us to hear from someone who knows exactly what they're talking about. Thank you so much. Thank you for the time that you spent with us. Thank you for all of the work that you're doing. We will, as you've requested, we're going to pray that people get vaccinated. We're going to pray that people wear masks, but we're also going to pray for you and all of the great work you're doing as well.
No, don't pray for me. Pray for the vaccine. That's what we need. I'll be all right. No, thank you guys. It's such an honor to be here. The most important thing to me is to get through this. And if I can help people understand what is really happening and how to access and how to take care of yourselves and prevent people from getting COVID, and how to access vaccine and how to feel good about doing that, then I am happy to talk to any audience anytime. I'm so sorry I didn't get to actually see your faces tonight, but hello to all of my friends and family who are out there. And we should do this again sometime, anytime that you need answers. Get my one message. It may not be your turn yet, but get your questions answered now. Get all your questions answered so that the minute you are eligible, you can take advantage of it and get your shot. You be ready to roll up your sleeve the minute that opportunity comes your way. If you're on all those waiting lists and someone says, oh, I need to get, we've got a spot at 3:00 this afternoon, drop what you're doing and go get that shot. It could save your life or the life of someone.
Thank you so much, Dr. Landon. On behalf of Bethany Lutheran Church too. Thank you so much. This is amazing. You're great.
Thank you guys. Good questions, everybody.
Just a reminder to everybody that this has been recorded. You can find it on Facebook right now. It's on First Congregational Church of Crystal Lakes Facebook page and our website and YouTube. We're going to send all those links to Bethany so that it'll be on Bethany's, all of Bethany's stuff soon as well. Again, thanks everybody for being here. Dr. Landon, if you look in the chat, there's like a million thank you things in there. I'm good.
Very nice of all of you, everybody.
Yep. All right. Thanks, everybody. Thank you so much. Thanks, Dr. Landon. Thanks for your time this evening. Take care, everybody. God bless. Be safe. Wear a mask. Get vaccinated.